Antiphospholipid antibody syndrome, APS, also known as Hughes syndrome, is an autoimmune disorder characterized by the presence of antiphospholipid antibodies, APL, in the blood, which can lead to blood clot formation in both arteries and veins. APS can cause a range of clinical symptoms, including recurrent miscarriages, stroke, deep vein thrombosis, DVT, and other thrombotic events. The condition can occur on its own, primary APS, or in association with other autoimmune disorders, such as systemic lupus erythematosus, secondary APS. Key features of APS. 1. Antibodies. APS is associated with the presence of antiphospholipid antibodies, including lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein 1 antibodies. 2. Thrombosis. Patients with APS are prone to developing blood clots in both veins and arteries, which can lead to conditions such as DVT, pulmonary embolism, stroke, and heart attacks. 3. Pregnancy complications. APS is a leading cause of recurrent miscarriages, stillbirths, and other complications like preeclampsia and intrauterine growth restriction. 4. Diagnosis. APS is diagnosed through a combination of clinical criteria, such as a history of blood clots or pregnancy complications, and laboratory tests showing persistent antiphospholipid antibodies. 5. Treatment. Treatment typically involves long-term anticoagulation therapy, e.g. warfarin or heparin, to reduce the risk of blood clots. In pregnant women, low-dose aspirin and heparin are often used to prevent pregnancy complications. 6. Prognosis. With appropriate management, many patients with APS can lead normal lives. However, the risk of recurrent clotting events remains a concern, necessitating long-term monitoring and treatment. Antiphospholipid syndrome, APS, is a complex autoimmune disorder, and understanding the role of antiphospholipid antibodies, APL, is central to its diagnosis and management. Here are more details about antiphospholipid antibodies. Number 1. Types of antiphospholipid antibodies, APL. There are three main types of APL associated with APS. Lupus anticoagulant, LA. Despite its name, this antibody prolongs clotting tests in the laboratory of coagulant, yet it increases the risk of thrombosis in patients. It's the most strongly associated with clotting events. Anticardiolipin antibodies, ACL. These target cardiolipin, a phospholipid found in cell membranes and platelets. They are detected using immunoassays and are associated with both thrombotic events and pregnancy complications. Beta 2 glycoprotein antibodies, anti-beta 2 GPI. These antibodies are directed against beta 2 glycoprotein 1, a protein that binds phospholipids. Like the other APLs, anti-beta 2 GPI is associated with an increased risk of thrombosis. 2. Mechanism of action. Endothelial dysfunction. APLs are believed to bind to the endothelium, lining of blood vessels, promoting an inflammatory response and leading to a prothrombotic state. Platelet activation. APLs may directly activate platelets, leading to their aggregation and contributing to clot formation. Complement activation. APLs can trigger the complement cascade, which further exacerbates inflammation and promotes clot formation. Interference with clotting regulation. These antibodies can interfere with the normal anticoagulant pathways in the body, tipping the balance towards excessive clotting. 3. Clinical manifestations. Thrombosis. The most significant feature of APS is thrombosis, which can occur in any blood vessel, leading to various complications depending on the location. Venous thrombosis, deep vein thrombosis, DVT, pulmonary embolism, PE, and Budd-Chiari syndrome, blockage of liver veins. Arterial thrombosis, stroke, myocardial infarction, heart attack, and peripheral arterial thrombosis. Pregnancy morbidity. APS is a major cause of pregnancy complications, such as recurrent miscarriages, stillbirths, preterm births, and preeclampsia. Catastrophic antiphospholipid syndrome, CAPS. This is a rare, life-threatening form of APS, characterized by widespread small vessel thrombosis, leading to multi-organ failure. CAPS requires urgent treatment. 4. Diagnosis. APS is diagnosed based on a combination of clinical criteria and laboratory findings. The Sydney criteria are commonly used. Clinical criteria. Vascular thrombosis. One or more episodes of arterial, venous, or small vessel thrombosis. Pregnancy morbidity. Recurrent miscarriage, 3 or more unexplained consecutive pregnancy losses, premature birth due to eclampsia or severe preeclampsia. Laboratory criteria: presence of lupus anticoagulant LA detected in plasma, medium or high levels of anticardiolipin ACL antibodies, positive anti-BET2 GPI antibodies. The antibodies must be present on 2 or more occasions at least 12 weeks apart. 5. Treatment and management. Anticoagulation. The cornerstone of treatment is anticoagulation to prevent further thrombotic events. This typically involves warfarin. For patients with a history of thrombosis, warfarin is the standard long-term treatment. The target INR, international normalized ratio, is generally 2.0 to 3.0. Heparin and low molecular weight heparin, LMWH, used in pregnant patients and those with acute thrombosis. Aspirin. Low-dose aspirin is often used in patients with APL, but without a history of thrombosis, particularly in women with recurrent miscarriages. Pregnancy management. Pregnant women with APS are treated with a combination of low-dose aspirin and heparin or LMWH to reduce the risk of pregnancy complications. Immunosuppressive therapy. In cases of CAPS or severe secondary APS, e.g. associated with lupus, additional treatments such as corticosteroids, intravenous immunoglobulins, IVIG, or plasma exchange may be used. 6. Prognosis. Long-term outlook. APS is a chronic condition, and patients require long-term monitoring and treatment to reduce the risk of recurrent thrombotic events. With appropriate management, many patients lead normal lives. Risk of recurrence. Recurrence rates of thrombosis can be high, especially if anticoagulation is stopped. This is why indefinite anticoagulation is often recommended for patients with a history of significant thrombosis. Pregnancy outcome. With appropriate treatment, women with APS can achieve successful pregnancies. Close monitoring by a rheumatologist and a high-risk obstetrician is essential. 7. Epidemiology. APS can affect people of any age, but is most commonly diagnosed in women of childbearing age, 20 to 40 years. It is more frequent in individuals with other autoimmune conditions, such as systemic lupus erythematosus, SLE, but can also occur in isolation, primary APS. There may be genetic predispositions, but APS is not directly inherited. Understanding APS and its complexities requires a multidisciplinary approach involving rheumatologists, hematologists, and other specialists to provide comprehensive care for patients. In addition to the primary antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein 1 antibodies, several other antibodies have been associated with antiphospholipid syndrome, APS, or exhibit similar properties. These non-criteria antiphospholipid antibodies are less well defined but can still be relevant in specific contexts. 1. Antiphosphatidylserine prothrombin antibodies. Antiphosphatidylserine antibodies. These antibodies target phosphatidylserine, a phospholipid found on the inner leaflet of cell membranes. They can be associated with APS and may contribute to the prothrombotic state. Antiprothrombin antibodies. These target prothrombin, a key clotting factor. Their presence may be associated with APS, especially in cases where other APL tests are negative. SHR2. Anti-annexin 5 antibodies. Annexin 5 is a protein that binds to phospholipids and has an anticoagulant effect. Antibodies against annexin 5 may interfere with this binding, promoting a prothrombotic state. 3. Antiphospholipid-dependent antibodies. Some antibodies may bind to phospholipids only in the presence of other proteins, such as beta-2 glycoprotein 1. These are not included in the standard APS criteria, but can still be relevant in certain cases. 4. Anti-lipoprotein A antibodies. Lipoprotein A is a complex of lipids and proteins that may be involved in clotting and cardiovascular disease. Some studies suggest that antibodies against lipoprotein A might be associated with APS. And 5. Antiplatelet antibodies. These antibodies target platelet-specific antigens and can lead to increased platelet activation, potentially contributing to thrombotic events. 6. Anti-phosphatidylethynolamine antibodies. Phosphatidylethynolamine is another phospholipid that, when targeted by antibodies, might be involved in the pathogenesis of APS. Clinical relevance, diagnostic challenges. The presence of these non-criteria antibodies can complicate the diagnosis of APS. They are not routinely tested, but might be considered in cases where standard tests are inconclusive or when clinical suspicion of APS remains high, despite negative results for the primary APLs. Prognostic value, the role of non-criteria antibodies in predicting APS-related complications or response to treatment, is still under investigation. Their presence may provide additional insights into the underlying mechanisms of APS and help refine patient management in specific cases. In clinical practice, the focus is typically on the standard APLs outlined in the APS diagnostic criteria. However, non-criteria antibodies can be important in certain scenarios, especially in complex cases or when standard testing fails to explain the patient's clinical presentation. Seronegative antiphospholipid syndrome, SNAPS, refers to a subset of patients who exhibit clinical features of antiphospholipid syndrome, APS, such as recurrent thrombosis or pregnancy complications, but test negative for the standard antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2 glycoprotein 1 antibodies. This creates a diagnostic challenge since these patients meet the clinical criteria for APS but do not have the laboratory markers typically required for diagnosis. Key points about seronegative APS. 1. Clinical presentation. Patients with SNAPS present with similar symptoms as those with traditional APS, including recurrent arterial or venous thrombosis, e.g., deep vein thrombosis, stroke, pulmonary embolism. Pregnancy complications such as recurrent miscarriages, stillbirths, preterm delivery, or preeclampsia. 2. Potential explanations for seronegativity. Non-criteria antibodies. Some SNAPS patients may have non-criteria antiphospholipid antibodies that are not routinely tested, such as antiphosphatidylserine prothrombin antibodies, anti-annexin Vi antibodies, or others, as mentioned earlier. These antibodies may contribute to the disease, but are not included in standard APS diagnostic criteria. Low titers. Antiphospholipid antibodies may be present, but at levels below the detection threshold of conventional assays. Transient positivity. APLs can fluctuate over time, so patients might have been seropositive at some point, but tested during a phase of negativity. Undiscovered mechanisms. There may be other pathogenic mechanisms contributing to the development of APS that do not involve currently known antibodies. 3. Diagnosis. Clinical criteria. In the absence of positive laboratory tests, diagnosis relies heavily on clinical judgment. A strong clinical history of thrombosis or pregnancy morbidity, particularly when no other clear cause is identified, raises suspicion for SNAPS. Non-criteria testing. Some clinicians may opt to test for non-criteria APLs or other related antibodies, though these are not standardized. Repeat testing. Patients suspected of having APS but initially testing negative may benefit from repeated antibody testing over time, as APL levels can fluctuate. 4. Treatment. Empirical anticoagulation. Treatment for SNAPS often mirrors that of seropositive APS, especially in cases of recurrent thrombosis or severe pregnancy complications. Empirical anticoagulation with warfarin or low molecular weight heparin may be considered to prevent further thrombotic events. Aspirin. Low-dose aspirin may be used, particularly in patients with pregnancy-related complications. Pregnancy management. Similar to seropositive APS, patients with SNAPS and pregnancy complications may be managed with a combination of low-dose aspirin and heparin during pregnancy. Number 5. Prognosis. The clinical course of SNAPS is thought to be similar to that of seropositive APS, with a risk of recurrent thrombosis and pregnancy complications. Long-term management typically focuses on preventing recurrence, even in the absence of confirmatory laboratory tests. Challenges and ongoing research. Lack of standardization. Since SNAPS is defined by the absence of standard APLs, there is no consensus on diagnostic criteria, making it more difficult to establish a diagnosis and initiate appropriate treatment. Research into mechanisms. Ongoing research is exploring other potential biomarkers and pathogenic mechanisms that could help identify and confirm SNAPS. Identifying novel antibodies or pathways may eventually lead to better diagnostic and therapeutic approaches. Seronegative APS remains a complex and somewhat controversial entity, but it is increasingly recognized by clinicians who encounter patients with APS-like clinical features but negative laboratory results. Individualized patient care and close monitoring are essential in managing these patients. The treatment of antiphospholipid syndrome, APS, is primarily focused on preventing thrombotic events and managing pregnancy complications. The treatment plan is tailored to the individual patient's clinical presentation, e.g., history of thrombosis, pregnancy issues, and whether they have primary or secondary APS, e.g., associated with lupus. The mainstay of treatment includes anticoagulation, antiplatelet therapy, and in some cases, additional immunomodulatory therapies. 1. 1. Anticoagulation therapy. Anticoagulation is the cornerstone of APS treatment, particularly for patients with a history of thrombosis. A. Warfarin, vitamin K antagonist. Indications. Long-term warfarin therapy is recommended for patients with a history of venous or arterial thrombosis. Target INR. For venous thrombosis, the target INR, international normalized ratio, is generally 2.0 to 3.0. For arterial thrombosis or recurrent thrombosis, the target INR may be higher, 3.0 to 4.0, depending on the risk of recurrence and clinical scenario. Duration. Anticoagulation is typically lifelong, especially after a major thrombotic event. Stopping anticoagulation can lead to a high risk of recurrence. Pack B, low molecular heparin, LMWH. Indications. LMWH is used in acute settings, e.g., during a thrombotic event and in pregnancy. Pregnancy. Warfarin is contraindicated during pregnancy due to teratogenic effects, so LMWH is used instead. LMWH is preferred over unfractionated heparin due to its more predictable pharmacokinetics and lower risk of heparin-induced thrombocytopenia, AT. C. Direct oral anticoagulants. Indications. The role of DOACs, e.g., rivaroxaban, apixaban, in APS is still under investigation. Current guidelines advise caution in using DOACs for APS, particularly in patients with arterial thrombosis or those with high-risk profiles, as studies have shown mixed results compared to warfarin. Limitations. DOACs may be considered in low-risk APS patients with venous thrombosis, but their use is generally not recommended in high-risk patients, particularly those with triple-positive APL, i.e. positive for all three standard APL tests. 2. Antiplatelet therapy, low-dose aspirin. Aspirin is used in patients with antiphospholipid antibodies who have not had a thrombotic event, asymptomatic APL carriers, or in combination with anticoagulation in patients with a history of arterial thrombosis. It is also used in pregnant women with APS to reduce the risk of pregnancy complications. Combination therapy. In some cases, particularly arterial thrombosis, aspirin is combined with warfarin to provide dual protection against clot formation. 3. Management of pregnancy in APS. Pregnant women with APS require specialized care to manage both the risk of thrombosis and pregnancy-related complications, such as recurrent miscarriages, preeclampsia, and intrauterine growth restriction. A. Low-dose aspirin plus LMWH. The combination of low-dose aspirin and low molecular weight heparin is the standard treatment for pregnant women with APS. This regimen has been shown to improve pregnancy outcomes by reducing the risk of miscarriage and other complications. Aspirin, 75 to 100 milligrams daily, is typically started preconception or early in pregnancy. LMWH is started as soon as pregnancy is confirmed and continued throughout the pregnancy and postpartum period. B. Hydroxychloroquine, HCQ. HCQ, an anti-malarial drug with anti-inflammatory and antithrombotic properties, is commonly used in patients with systemic lupus erythematosus, SLE-associated APS. It may also benefit pregnant women with APS, potentially reducing the risk of thrombosis and pregnancy complications. C. Intravenous immunoglobulins, IVIG. IVIG may be considered in women with recurrent pregnancy losses despite standard treatment with aspirin and LMWH. It is also used in severe cases of catastrophic APS or in patients with refractory disease. 4. Catastrophic antiphospholipid syndrome, CAPS. Management. CAPS is a rare but life-threatening form of APS characterized by widespread small vessel thrombosis and multi-organ failure. It requires aggressive treatment, often involving high-dose corticosteroids to reduce inflammation, plasma exchange, plasmapheresis to remove circulating antibodies, intravenous immunoglobulin IVIG as an immunomodulatory treatment, anticoagulation, full-dose anticoagulation with heparin or LMWH. Rituximab or cyclophosphamide. In refractory cases, these immunosuppressive agents may be considered. 5. Secondary prevention, asymptomatic APL carriers. Low-dose aspirin. Some clinicians recommend low-dose aspirin for asymptomatic individuals with antiphospholipid antibodies, particularly those with a high-risk profile, e.g. triple-positive APL or additional cardiovascular risk factors. Close monitoring. Regular follow-up is essential for asymptomatic APL carriers, as they may develop thrombosis or other complications over time. 6. Other considerations. Lifestyle modifications. Patients with APS are advised to avoid other risk factors for thrombosis, such as smoking, oral contraceptives, and prolonged immobility. Regular monitoring. Patients on anticoagulation therapy require regular monitoring to ensure appropriate anticoagulant levels and to assess for potential side effects, e.g., bleeding, warfarin-induced skin necrosis. Treatment of underlying autoimmune disease. In cases of secondary APS, e.g., APS associated with systemic lupus erythematosus, controlling the underlying autoimmune disease is crucial. This may involve the use of corticosteroids, immunosuppressants, and biologic therapies. 7. Future therapies. Ongoing research is exploring new therapeutic options for APS, including statins. These drugs may have anti-inflammatory and antithrombotic effects in APS, though their use is still investigational. Monoclonal antibodies. Agents like rituximab, which targets B cells, and eculizumab, which targets the complement system, are being studied for their potential roles in refractory or severe APS. Conclusion. The treatment of APS is individualized and often requires a multidisciplinary approach involving rheumatologists, hematologists, obstetricians for pregnancy management, and other specialists. Lifelong anticoagulation is typically required for patients with a history of thrombotic events, while pregnant women with APS are managed with a combination of anticoagulation and antiplatelet therapy. Ongoing research into APS is focused on improving treatment strategies and exploring new therapeutic options. The concept of antiphospholipid syndrome APS as a type of thrombotic systemic lupus erythematosus SLE is an interesting and sometimes debated perspective, but it is not universally agreed upon in the medical community. Here's a closer look at the reasoning behind this view and the general consensus on the relationship between APS and SLE. Number 1. Overlap between APS and SLE. Co-occurrence. APS and SLE frequently overlap. Approximately 30 to 40% of patients with SLE have antiphospholipid antibodies, APL, and about 10 to 20% of these patients will develop full-blown APS with clinical symptoms like thrombosis or pregnancy complications. Conversely, a small percentage of patients initially diagnosed with primary APS may go on to develop SLE or other autoimmune conditions over time. Shared autoimmune mechanisms. Both APS and SLE are autoimmune diseases characterized by the production of autoantibodies and chronic inflammation. In SLE, there is a broad spectrum of autoantibodies, including anti-dsDNA, anti-SM, and others, while APS is defined by the presence of antiphospholipid antibodies. The concept of APS as thrombotic manifestations. SLE itself can lead to thrombosis, particularly in patients with antiphospholipid antibodies. Because APS is primarily defined by thrombotic events, venous or arterial, and pregnancy complications, some have proposed that APS might represent a thrombotic variant of SLE, even in the absence of other typical SLE symptoms like skin rashes, arthritis, or nephritis. Pathophysiological similarities. Both diseases involve immune dysregulation and abnormal responses to self-antigens. Some researchers propose that APS could be part of the broader spectrum of SLE, where thrombosis is the predominant manifestation rather than the classical features like rash or kidney involvement. 3. Counterarguments. Distinct clinical entities. Many experts consider APS and SLE to be distinct clinical entities, even though they can overlap. APS can occur as an independent disease, primary APS, without any other signs of SLE or other autoimmune conditions. The presence of antiphospholipid antibodies and thrombotic events in APS are not necessarily accompanied by the systemic inflammation seen in SLE. Different pathways and outcomes. While both diseases involve autoimmunity, the clinical outcomes and long-term management strategies can differ. Patients with primary APS may only require anticoagulation and not the immunosuppressive therapies often needed in SLE. 4. Current consensus. APS as a distinct syndrome. Most current guidelines and expert consensus treat APS as a distinct autoimmune syndrome. Primary APS is considered its own entity, separate from SLE, although there is recognition of the overlap and the higher risk of APS in patients with SLE. Terminology. The term thrombotic SLE is not widely adopted in clinical practice or formal classifications. Instead, APS is recognized as either primary, occurring on its own, or secondary, associated with SLE or other autoimmune diseases. When APS is associated with SLE, it is managed within the broader context of lupus treatment. 5. Clinical implications. Management differences. The management of APS and SLE differs. APS primarily involves anticoagulation to prevent thrombotic events, while SLE management focuses on controlling systemic inflammation with immunosuppressants and corticosteroids. Even when APS and SLE coexist, the treatments are tailored to address both the thrombotic risk, APS, and the systemic autoimmune activity, SLE. Prognosis. The long-term outcomes for patients with primary APS versus those with SLE-associated APS may also differ. For instance, patients with SLE have a higher risk of systemic organ involvement, which is not typically seen in primary APS. Conclusion. While some authors view APS as a thrombotic variant of SLE, this view is not universally accepted. APS is generally considered a distinct entity, even when it coexists with SLE. However, the overlap between the two diseases is recognized, and their relationship continues to be an area of ongoing research. Managing patients with APS and/or SLE requires a careful and individualized approach, considering the specific manifestations of each condition. Catastrophic antiphospholipid syndrome, CAPS, is a rare but life-threatening variant of antiphospholipid syndrome, APS, characterized by rapid, widespread thrombosis that leads to multi-organ failure. Unlike typical APS, which usually involves single episodes of venous or arterial thrombosis, CAPS involves the simultaneous occurrence of multiple thrombotic events, often affecting small vessels in various organs. Early recognition and aggressive treatment are essential to improve outcomes, but the mortality rate remains high, even with optimal care. Key features of catastrophic APS, CAPS. 1. Clinical presentation. Rapid onset. CAPS develops suddenly, usually over days to weeks. Patients often present with signs and symptoms of multi-organ failure, which can include respiratory distress, altered mental status, renal failure, skin necrosis, and more. Multi-organ involvement. CAPS typically affects at least 3 organ systems simultaneously. The most commonly involved organs are kidneys, acute kidney injury or renal failure due to small vessel thrombosis; lungs, pulmonary embolism, acute respiratory distress syndrome ARDS, or pulmonary hemorrhage; central nervous system, stroke, seizures, or encephalopathy; skin, livedo-reticularis, purpura, and skin necrosis; gastrointestinal system, mesenteric ischemia or hepatic failure; heart, myocardial infarction, cardiogenic shock, or valve involvement, Liebman-Sachs endocarditis. 2. Triggers. CAPS often occurs in the context of a precipitating factor, such as infection, particularly bacterial or viral infections; surgery or trauma. These can trigger the onset of CAPS in susceptible individuals; discontinuation of anticoagulation. Stopping anticoagulation therapy in an APS patient can lead to CAPS. Pregnancy. CAPS can occur during pregnancy or in the postpartum period. Medications. Some drugs, including oral contraceptives, can trigger CAPS. 3. Diagnosis. Clinical criteria. Diagnosis is based on clinical presentation, with the key features being the rapid onset of multiple organ thrombosis and the involvement of at least 3 organ systems. Laboratory tests can confirm antiphospholipid antibodies, but the urgency of the situation often necessitates clinical diagnosis before all test results are available. Laboratory findings. The standard antiphospholipid antibodies, lupus anticoagulant, anticardiolipin antibodies, anti-beta-2 glycoprotein 1 are often positive, but their presence is not required for immediate management if clinical suspicion is high. Other findings may include elevated D-dimer, signs of disseminated intravascular coagulation, DICE, and microangiopathic hemolytic anemia, e.g., schistocytes on blood smear. Imaging. Imaging studies may reveal evidence of thrombosis in various organs, e.g., CT scans showing pulmonary embolism, Doppler studies indicating deep vein thrombosis. 4. Pathophysiology, small vessel thrombosis. In CAPS, the thrombosis predominantly affects small vessels, leading to microvascular occlusions that cause tissue ischemia and multi-organ dysfunction. Systemic inflammatory response. CAPS is associated with a systemic inflammatory response, which can amplify the thrombotic process and contribute to organ damage. Complement activation. Recent research suggests that activation of the complement system may play a role in CAPS, contributing to endothelial damage and promoting thrombosis. Management. CAPS is a medical emergency that requires a multidisciplinary approach. The treatment is aggressive and involves several strategies. Anticoagulation. Heparin. Intravenous unfractionated heparin is the mainstay of anticoagulation in CAPS. It should be started as soon as possible and continued until the patient stabilizes. Once stable, patients are transitioned to long-term anticoagulation with warfarin or another suitable agent. High-dose corticosteroids. Indications. Corticosteroids, e.g., methylprednisolone, are used to suppress the inflammatory response that contributes to the thrombotic process. Plasma exchange, plasmapheresis. Indications. Plasma exchange is used to remove circulating antiphospholipid antibodies and other prothrombotic factors. It is typically done daily until clinical improvement is observed, usually in combination with anticoagulation and other therapies. Intravenous immunoglobulin, IV indications. IVIG can be used as an adjunctive therapy, particularly when plasma exchange is not available or contraindicated. IVIG may help modulate the immune response and reduce antibody-mediated damage. Rituximab indications. Rituximab, a monoclonal antibody that depletes B cells, may be considered in refractory cases of CAPS or in patients with concomitant autoimmune conditions such as lupus. It targets B cells, which are responsible for producing autoantibodies. Cyclophosphamide. Indications. Cyclophosphamide, an immunosuppressive agent, may be used in severe cases of CAPS, especially in patients with underlying systemic lupus erythematosus, SLE, or other autoimmune diseases. Eculizumab. Indications. Eculizumab, a complement inhibitor, has been used in some cases of refractory CAPS, particularly when complement activation is suspected to be a driving factor in the disease process. 6. Prognosis. High mortality. Despite aggressive treatment, the mortality rate for CAPS remains high, ranging from 20 to 50%. Mortality is often due to multi-organ failure, sepsis, or other complications. Early intervention. The prognosis improves with early recognition and rapid initiation of a combination of anticoagulation, immunosuppression, and plasmapheresis. Delayed diagnosis and treatment are associated with poorer outcomes. 7. Follow-up and long-term management. Lifelong anticoagulation. Patients who survive CAPS generally require lifelong anticoagulation therapy, usually with warfarin. Maintaining an appropriate INR, often between 2.0 and 3.0, is crucial to prevent recurrent thrombotic events. Monitoring for relapse. Survivors of CAPS are at risk for recurrent thrombotic events, so close monitoring and regular follow-up are essential. Additionally, identifying and managing potential triggers, e.g., infections, surgery, is important for preventing recurrence. Multidisciplinary care. Patients with CAPS benefit from a team approach that may include rheumatologists, hematologists, nephrologists, intensivists, and other specialists, depending on the organs involved. Conclusion: catastrophic antiphospholipid syndrome, CAPS, is a severe and rapidly progressive form of APS that requires prompt diagnosis and aggressive treatment. The management involves anticoagulation, immunosuppression, and plasma exchange, with the goal of controlling the widespread thrombosis and systemic inflammation. Despite advances in therapy, CAPS remains a highly lethal condition, and early intervention is critical to improving survival rates.